Tonight's International Dermatology Education Foundation Educational Series Webinar. My name is Ashley with RBC Consultants, and the title of tonight's webinar is Demand More with Bimzelx. Bimzelx is indicated for the treatment of adults with moderate to severe HS. As our moderator this evening, we have Dr. James Del Rosso. He is Research Director and Principal Investigator, JDR Dermatology Research in Las Vegas, Nevada, Adjunct Clinical Professor of Dermatology at Touro University in Nevada in Henderson, Nevada, and President of the American Acne and Rosacea Society. As speaker this evening, we have Dr. Christopher Syed, Professor, Department of Dermatology at the University of North Carolina in Chapel Hill, North Carolina. We would like to thank our supporter this evening, UCB, for making this educational event possible. Before we begin, a few logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having any technical issues, please submit your questions in the question pane on the right-hand side of your screen. And at the end of this webinar, a survey will pop up in your browser and will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this quick survey. And also within 1 to 2 days of the webinar, you will also receive a certificate of attendance via email. At the end of the program, we will have a Q&A, so if you have any questions for our moderator or our speaker, please use the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Del Rosso.
Thanks a lot, Ashley. It's certainly a pleasure to have the opportunity to be participating in this program tonight, filling in with Dr. Kircik, who was not able to make it tonight. Dr. Kircik, Leon Kircik, well known in dermatology. He is the founder and president of the International Dermatology Education Foundation, which has been running successfully for quite some time. You can see all of his affiliations there. If I read his CV, it would take longer than we have for tonight, so we won't do that. But we do want to honor what he's done with the IDEF. It has a mission to raise awareness and provide education throughout the United States and around the world, and trying to reach underserved areas where maybe there are not the educational programs that we have so many, but we're happy to have you here tonight. Next slide, please. So there's been several previous sessions and there'll be other ones coming up. So I want to make sure you know how to access the programs through the IDEF. Next slide. So stay up to date with the IDEF educational seminars. You can see here through Instagram, LinkedIn, and Facebook, or you can go to the website, www.idefeducationalseries.com, to register for any of the upcoming programs. There are several, and these are excellent programs. And we expect another excellent program tonight. We have someone who is a true Tar Heel. He was born by the coast of North Carolina there and lived in Wilmington for a while, and then ended up at University of North Carolina where, right, Chris, you've been there the whole time. Professor of dermatology. Yep. So the tar kept you stuck right there, right? So he's at the Department of Dermatology. He does a lot of things there. He's been there for some time. He does clinical trials, sees patients, does a lot of teaching, and he's very involved with translational research. And I guess you might say you wear the hat of directing, trying to centralize how hidradenitis suppurativa is being managed in your facility, and it's growing, right? There's a lot of new information and a lot of new treatment. So I'm going to turn this over to you so you can start the program, and thanks for being here.
Of course, thanks so much for the kind introduction and for a chance to speak on HS. I'm always excited to have a chance to speak to 1 or 2 providers in the room, to speak to close to 90 people all at once and share some information about HS. Always feels like a really big deal, so I appreciate the opportunity to do that. And of course, it's always fun if it's more conversational. Please, chime in with questions. I'm happy to keep some time for discussion at the end and stay on as long as people want to hear me keep on talking, because I could talk about HS all day. As Dr. Del Rosso mentioned, I've been at UNC for a long time, since undergrad, and joined the faculty about a dozen years ago. And at that time, nothing was FDA approved for HS. It was, really struggling forever. Your last treatment, you wanted to get a patient, and most things didn't work nearly as well as we wanted them to. And it's sort of been somewhat lucky to sort of be on this wave and see a series of new treatments come around that we can use that clearly make a much bigger difference for our patients. And we're sort of still in the upswing of all that, but I think we're really starting to see where it's not just, one therapy, for several years like it was for so long, but those next line therapies coming up that seem like they're going to do better and better and offer more options. So, of course, the focus of this talk is going to be on Bimzelx, which is the most recently FDA approved drug. Almost a year now, coming up on that anniversary of approval, and I can tell you I have a ton of patients on it. It's got a very useful place in the treatment paradigm, and I'll try to talk a little bit about just practically how I put it into play. Where I think it's important to counsel patients to some extent, but for the most part, it's a great trade-off in terms of benefit and sort of the small things we have to counsel about. But I'm going to go ahead and jump into it here. I should have slide control. There we go. So again, this is just again highlighting that hopefully we are going to raise expectations at this point. It's more than about just very basic results. When I was again starting off, it was patients came in on doxycycline and they left with minocycline. Nobody in the room expected them to get better, but now the expectation is much higher, and we have to meet that expectation. It's disclosure. Again, this is sponsored by and on behalf of UCB. I do consulting work with them also. I'll do my best to be as unbiased as possible. I'm happy to talk about a complete treatment paradigm, beyond just this medication, but it has an important role to play. I think everybody that's here is familiar with HS. You probably wouldn't sign up for a talk on HS, but of course the classic lesions are inflammatory nodules, abscesses, and then tunnels, whether they're draining or not. In this picture here of the tunnel, there's really not any draining present, but you can see these areas where it looks like kind of large comedones almost, where if you pushed a little probe through them, you'd slide under the surface and pop out somewhere else. So there really is a physical remodeling of the skin that happens in this disease that makes it unlike any other. I mean, this is really the thing that makes it so difficult, is that once that skin has remodeled, it is very hard to correct that over time. A psoriasis patient, I can treat them for 12 weeks, their skin can look normal. Whereas with HS, once the damage is done, just like with bad, severe scarring acne, there is no going back a lot of times, no getting it back to completely normal again, which just makes it really important to jump in early and try to avoid this kind of change. And the other thing that's so hard about HS, more so than other things that we treat, is that inflammatory nodules and abscesses are inherently painful. That is the number one thing patients complain about. It is the overriding thing when they come into the room. I think it is what makes these visits so stressful sometimes, is that as dermatologists, we are probably not the very best at managing pain and sort of having to work through those algorithms. So it gets overwhelming when a patient is suffering and tearful and it's such a big part of their disease. But the nice thing is that when we manage disease well, we manage that pain as part of the disease management, right? The medications we use to calm the inflammation down help with pain along the way. And if we pick up some new ways to treat pain, with them in the acute setting, I think that goes a long way too, which I'm happy to talk about that some as we go on.
Well, Chris, one of the things that's interesting is just the way the studies are designed. The primary endpoints aren't even discussing the issue of pain, but that's what the patient comes in and tells us about. The secondary endpoints are typically the primary endpoints in clinical practice. Would you agree?
That's absolutely right. I mean, but and in many ways, that's like psoriasis. The FDA always talks a big game about patient-reported outcomes and how much they care about them, but they always want a physician-reported outcomes. Yeah, we're counting lesions. That's always the thing that makes or breaks the study. But what patients want to be able to come in and say is, look, I'm not hurting nearly as much as I was. And there is some very nice data that we'll get to later that really sort of focuses on pain and helps us understand how much it improves for patients and how to set that expectation. An abscess, like in this middle picture here, is the worst lesion a patient can have. They can have just one lesion. They can go from 10 lesions to one, and they can still be miserable because of one abscess. So those are the hardest ones to sometimes help patients through when they start acting up. And then, of course, I think much more so than other conditions we treat, the sort of physical disability that goes along with this disease is much greater. Of course, there's palmoplantar psoriasis, there's other things that impact how patients can work and how they feel and interact with the world. But I think most of us on this call right now would say, like, if we had to spin the wheel of bad luck for dermatology disease and it was atopic dermatitis or psoriasis or, HS was on that wheel, I think HS is one of the very last things we would be, crossing our fingers it doesn't land on, because it has so much impact early on in life. It's something that kind of carries forward, after you're out of school, as you go into work life, how you build relationships early in life, since it often starts in adolescence. And so it builds, and because it has so many ups and downs, it's such a roller coaster. Patients often just feel so on edge, like, how am I even supposed to go on vacation if I could flare up, 3 days from now and I'm stuck somewhere with no medication and no bandages, or an abscess ruptures, when I'm sitting in class next week. It is such, a sort of stressful thing to have in your mind all the time that something like that could happen. The highs and lows happen so quickly, more so than other diseases.
And the sensitivity of the anatomic locations in so many ways, right? You're talking about the groin, you're talking about on the breasts or under the breasts, and a lot of times patients don't even want to show you these areas because they're so embarrassed.
Exactly. I mean, for us, we see it all the time, but for them, it's the first time they've showed it to somebody a lot of times, right? They haven't even wanted to show if they're young, they haven't showed their parents. I have, husbands and wives that come in together and like they want their spouse to step out of the room for the exam because they're just so embarrassed they haven't been able to even show their spouse these areas. So it is something people really suffer with very quietly. It's nice that is changing in some ways, like the discussion out there on social media around HS has grown like crazy. There was an event 2 weeks ago in Times Square, and UCB and other companies helped sponsor it with some of the patient support groups where they bought out all the huge lit up billboards in Times Square. They had images of HS and the scars that were shown. Patients went out in their underwear and like showed off their scars on a runway. It's really incredible, how much people have been able to start this discussion and raise public awareness. So my hope is 10 years from now, you can say eczema and psoriasis and hidradenitis, and the general public kind of knows a little bit about all those things, but we still have a long way to go on that.
Yeah.
And so, there are things like patient preference studies that are done asking patients, what do you want out of treatment, right? Just like Dr. Del Rosso mentioned earlier, pain reduction is probably the number one thing that if you ask a patient, what do you want out of your treatment, they just want to hurt less is number one. But on top of that, it's, fewer lesions that are present, things like surgery that are such a big part of HS care that are not for all the other inflammatory diseases that we treat are things that patients are hoping to avoid. And that's a really hard bar to hit. The idea that these areas that are chronically tunneled and look like they're going to probably need surgery to start with, can you get it to the point that a patient can live without having to go through surgery? And that's a big goal that is, again, a high bar to meet. And the studies of the clinical trial and the clinical trials for this drug in particular, getting to see patients, every 2 weeks and every 4 weeks and see how it starts and watch so closely how some of those areas do seem to transition to almost scar-like change was really impressive. Something that I feel like I don't have a chance to see or sort of pay much attention to when a patient comes back 3 months after they start and I can't remember exactly what was there to begin with. But watching some areas, be able to do that was very impressive. It doesn't happen, of course, 100% of the time, but I think that is a huge advantage of therapies that have deeper responses. Not just that.
So Chris, what in your clinic, you're probably seeing a lot of people, especially now that there's somebody there that has a strong interest, that have been around the block and have been through those years of cycling through antibiotics, and really you can't blame anybody because we didn't have anything that was really affecting the underlying disease. And it was maybe hard for some of those people to come back because they gave up hope. And now they're coming to see the big shot at the university that's supposed to work miracles, and you have, but how do you handle this on that first visit with that patient? Because there's so much to go over. So what's your recommendation to people that have less experience of how to capture that patient the first time they're coming in after they've been around the block a few times?
Absolutely. I mean, getting, these visits, I think, are sort of something that some providers are a little bit afraid of because they can get off the rails a bit. There's a long, like you said, history those patients have dealt with of all the things they've been on, all the people that have tried to help them and maybe haven't helped them as much as they were wanting. Now, you could hear a story that takes 30 minutes for a patient to tell. So, one of the main things I do first is try to collect the key information. What have you been on? What's worked? What hasn't worked? And ideally, I have a handout that we give to patients ahead of time, or if you have a nurse that's collecting information, just the highlights of, what have you been on so far? What's working and not working? What kind of surgical procedures have been done in the past to get a sense of what their experience has been in that realm, because it's something that many of them will have to visit at some point potentially. And then I try to quickly tell their story back to them as the first step. I know you've dealt with this for a long time. It looks like you've been on each of these medications and they really just haven't done as much as you need them to do so far. I think there are some other things that we can do for you. And so I try to dive into that pretty quickly rather than, and sort of let them know I've heard it. I know what they've been through, but let's make sure we have a chance to focus on, getting you better. And then next step is and then one of the key questions I ask is whether their disease is relatively stable, especially when they come back on treatment. Are you getting new lesions spreading in new areas, or do you just have specific areas that just continue to flare, just haven't healed quite all the way? Because if it's mostly just a few stubborn tunneled areas and the medication is keeping new things from coming, they're overall doing better, that means that maybe surgery needs to be the main focus to fix those areas that are just resistant to medication alone, at least in the short term. And then they can be great on medication after that if you can keep their disease stable afterwards. So understanding stability versus instability is really key to know how much we need to change things. And then in the exam, you know, at least for underarms, I try to show them and I have them hold a mirror as I'm kind of looking, and I say, you know, some things are coming and going, like these nodules, where these tunnels are, and I kind of point out, and they understand the concept of a tunnel very well. These are the things that might have the most difficult chance of responding to this medication alone. I think with medication, I'm going to help you hurt less and have less drainage. I want you to be more physically active and do the things that you want to do. You know, if these are the areas that don't quite respond all the way, that's where surgery might be part of getting you the best you can be. And so I try to lay out that expectation, not you have to go to surgery tomorrow, but, you know, if we have the disease, once the disease is stable, you know, that might be something we have to think about to get you the best you can be. And that way, if they come back and they are hurting less and draining less, but it's just those few resistant areas I showed them, that we've kind of set the stage for that next step. You know, HS is a project much more than, you know, or so go ahead.
Sorry, I'm sorry. I was just going to say they have confidence they have somebody that knows the disease and is going to help them with it, you know, you walking through that. So I think that's a great approach. Thank you.
Of course, of course. Yeah, it really is, you know, laying out that plan of like, I think there is a way to get you better. You know, I say, I wish I could get you better to where you want to be in just 3 months and everything was done. You know, the first step is let's get it under good control. You know, those next steps are going to be part of getting you the best you can be. And that might be 6 months or a year, could be 5 years, depending on how fast, you know, you feel like you can go down that path and sort of, you know, if there's things like surgery necessary, getting those things done. But at the end of that path, I think I can get you much better. You know, that idea that you instill some confidence of, it's not an easy road, but at the end of that road, there is a much better life to expect, hopefully.
Good.
Like I said, I could talk about HS all day. I'm gonna keep us rolling here. And so, you know, the idea here, I've kind of mentioned this already, is that you have, you know, a key time at which you can approach this disease where you can hopefully stop from progressing and leaving irreversible damage behind, right? Just like you don't see a patient come in with terrible scarring cystic acne and you say, let me try this and that for a year or 2 years and all the scars are there after that, you can't reverse that. You're probably going to offer that patient an oral retinoid sooner rather than later, rather than waiting for all the damage to be done. And that's the same here. You know, as soon as a patient has some tunneling and scarring that's developed, that is my threshold, right, in this early disease state, to go ahead and stop that disease in its tracks, rather than say, I'm going to wait till it's the worst it can be and then only pull out the big guns then, right? That is sort of, you know, totally counterintuitive in my mind. You know, it's very clear from a lot of data from trials that the earlier you intervene, that the higher the ceiling, or such that, make sure I get this right, you know, the higher likelihood you have having really great responses, right? If you want to aim for a high score 75, like, and that'd be the very best you can possibly get because there's so much scarring and tunneling, the longer you wait, the more likely you are to have difficulty passing a benchmark like that.
Right.
If you intervene early, before that happens, you're much more likely to get a patient totally clear of inflammatory lesions and minimize that risk of surgery.
Well, one of the problems we've had, though, is with the Hurley scores, and you go back and look at, but it was 2015 was when we got the first drug. We got Humira, right? And then, you know, just the last couple of years with the anti-IL-17s, as you mentioned. But if you looked at Hurley 2, scarring was already there. And that's when they said, okay, now we're going to start thinking about systemic therapy. So it was backwards, right, from what you just said. And we have to change that way of thinking. Right.
Exactly. It's really challenging because in clinical trials, you need, you know, some baseline level of disease activity to improve to be able to measure success. And it's really hard to do that in early disease. Like, if there's no inflammatory lesion and that's your benchmark and you only have people with 1 or 2, it's really hard to see like when it gets better. So we need better measures to catch early disease and sort of really measure responses. Yeah, but most of the indications are moderate to severe disease, which means, you know, even if the patient doesn't have 5 lesions that day, you know, they probably would tell you, you caught me on a good day, right? And if they're telling you that and they've got scar, you know, even 1 tunnel present, like, in my mind, moderate to, and they're especially recalcitrants to other treatments, they can hit that benchmark very easily. So yeah, clinical trial criteria versus, you know, what we treat in real life ends up having some separation in a lot of cases.
Do you have any ways to see what is going on underneath? Like, do you use any ultrasounds or anything to see? Because we're basing it on what we see on the surface, but there could be a heck of a lot more going on underneath, right? So are there any techniques that you're using to do that?
Yeah, it's a good question. Like, some people do use ultrasound. You know, it is time intensive, and one of those things that I think if you see a fair bit of HS, like over time, I think the ultrasound doesn't tell you that much more. You know, the patient can tell you a lot, and then, you know, palpation is your other best friend, right? Like, you know, it's you can look and kind of see what's there to some extent. You know, gently kind of feeling for firmness. You know, if there's an area that you think might be a tunnel, you'll feel a ridge where it runs most of the time, and there's that firmness that's there. And the patient can tell you, like, you know, say, can you show me where you usually have trouble, especially like in the axilla with a mirror. They'll often put their finger right on it and say, yeah, this is quiet today, or if I push, it's a little bit tender right here. You know, they can help sort of identify some of those areas that are a bit inflamed that may not be obvious by just looking. And then again, like if there is that same recurrent spot where they're like, it's not tender today, but next week it will be, or right before my menstrual cycle every month, this is the area that gets inflamed again. It's going to tell you where some of that long lasting, you know, tunneling or damage has been done.
I mean, if you're standing a foot away or 2 feet away and you're not getting closer or looking or asking those questions, you're going to miss the severity of the disease in your clinical assessment. That's what I'm hearing, basically, what you said.
No, I mean, you know, I'm in there. It's like, you know, I'll hand them the mirror so that I can be in there and sort of gently palpating and kind of feeling where they're pointing as they show me. You know, same for groin area, perianal area. You know, being able to look clearly, you know, palpate gently. If it is super inflamed, it's going to be obvious and it's going to hurt if you press. You're not going to push hard on areas like that. But for areas that maybe are kind of subtle or they're pointing them out to you, you know, feeling very gently, you know, helps you get a sense of exactly where it extends under the surface most of the time. And so again, like, you know, the idea here is, again, disease activity waxes and wanes. I was talking about the roller coaster of putting up with HS, you know, that uncertainty of when these peaks and troughs happen is something patients never know. And it happens at the worst possible times when you're traveling or when they're stressed. And then as that flares over and over again repeatedly, that leads to additional functional impairment, right? Where you have areas that are chronically draining on a place like the lower buttock crease. So sitting becomes painful, using people's arms for work becomes functionally more difficult. It's also where, you know, things like how people plan what clothing they're going to wear. They'll tell you, I only have black clothing in my closet because anything else will show the stains from when I'm having drainage or when I'm having bleeding. And so this is where it really reshapes how people make a lot of decisions in their life. And then the irreversible damage with things like scarring, you know, it's relatively unusual to see things like tethering and reduced range of motion from true scarring, but again, inability to use your arms because you're hurting all the time and getting stiff shoulders and neck because you just can't use your arms and shoulders the way you want to. You know, these are real issues that build up as time goes on with uncontrolled disease. And so, you know, switching gears to talk more specifically about Bimzelx, what's unique about it is that it is not just IL-17A like others that have been approved before, but both IL-17A and F. And the nice thing about that is I'll show you in a moment here. I want to make sure I'll wait till we get to that slide, but the idea here is that IL-17A certainly plays a role in HS, and it is the most potent stimulator of the IL-17 receptor, but IL-17F also stimulates that receptor, and there is a lot more around of it than there is of IL-17A. And so if all you block is IL-17A, you still have plenty of stimulation of that IL-17 receptor. So you get a more complete blockade of this pathway with something that blocks both of those at the same time is the idea. And so I think that's why we see some difference in my mind when it comes to overall rates of response. And when people do respond, instead of having powerful responses, it's a much deeper response a lot of the time. So I think it kind of reflects that mechanism of action. And again, prevents these stages of advancing of where you get, you know, uncontrolled inflammation that leads to chronically inflamed tunnels that then are much more difficult to resolve. When you stop it in this earlier stage, you hopefully keep as many tunnels from forming over time. So it's about not just relief of that pain, but hopefully disease stabilization where you don't see more damage being done over time. Again, this is just kind of putting that into an image here where, you know, IL-17A is around, of course, but there is just much more IL-17F. And if you can only block, you know, one of these dimers here, this IL-17, you know, dual A dimer, you're really not putting out the fire as well as you need to. And when a fire is roaring like it is in HS, you know, you can't leave those embers around to just relight it all the time. And again, just a closer look here again about that dual blockade, just making sure we drive that point home. Moving along, one more here. It's got a slight lag. I want to make sure not to dance us too far. Okay, so at this point, just, you know, thinking about how long Bimzelx has been around overall, what the experience is in clinical trials. Again, it's newer to the market in the HS world and sort of has been around for psoriasis a bit longer, but there have been many, many patients that have been studied with placebo-controlled periods with this drug to give us a very good sense about safety. The been 11 phase 3 trials, more than 15 years of trial use across all indications, and tens of thousands of patients that have been exposed at this point. So, when you think about possibility of rare side effects, once you get to 15,000 patients, that's going to help you pick up on those sort of 1 in 5,000 type events. Once you get to 40,000 patients, you've really got a good sense that you're not going to start to hopefully see rare things pop up with any kind of frequency that becomes meaningful over time. So very reassuring to see that. Of course, it is approved for psoriasis and psoriatic arthritis also at this point. It's got fantastic psoriasis data. It is, patients who have had failed many other drugs with psoriasis have done, way better on this one. And so I think it's got its, definitely a group of patients where they're just very, very sensitive to it and do fantastically well. Of course, we're gonna talk about HS mostly tonight though. And again, the idea that we should raise our expectations and hopefully, do better than the sort of those baseline expectations we expected for years and that patients expected for years, is that it's not, high score 50 tends to be the usual benchmark to hit, right? And if I told you you have 10 abscesses today, and if we're lucky, you're going to get down to just 5 abscesses, and that's, going to make your life that much better, right? It's an improvement, but it is also just not good enough. Like most patients with a 50% improvement, they'll say, yeah, I can tell it's doing something, but I still have a lot of HS, right? And it still is affecting how I work, how I live my life. So it is a nice benchmark, but it is not the benchmark that brings a patient back that says, I am super happy, I love this drug, never take this away from me. And the higher we push, the more we get that. That is for sure at this point. And so, if in a high score 50, isn't an exact relationship to 50% disease reduction. There's some caveats where you also can't have increased draining tunnels or increased abscesses. But in general, it's about a 50% reduction in inflammatory lesions. That means, again, there's still going to be erythema, pain, a lot of the symptoms that were there before. When you get to high score 100, that means, there might be some scarring left behind that you just can't do much about with medication, but they are going to be typically pretty much pain-free, have very little, shouldn't really have any drainage at all, because there should be no sort of minimal drainage around or none. And they are going to be highly functional at that point. So that is a great benchmark to hit, and something that is very, very difficult to do in general. And so if we look at just week 2 results, again, it's always nice to see, like, when are patients going to be able to come back early? Are they going to buy into the drug after a dose or two and feel like they really are seeing improvement? So even within 2 weeks, you start to see a split with this medication, right? So it's 22%. It is not an overwhelming majority, because with HS, there are wounds that take time. If you have a scraped knee and you put somebody on medication to sort of help reduce inflammation, it doesn't heal any faster necessarily. You have to put the fire out and let there be some time for healing. But even within 2 weeks, things have started to move the right direction, where some of those areas where there's some nodules that are present are starting to fade. As you get through week 4, you see that more areas have had a chance to start healing and really improving, and the redness has had more time to fade. And by week 16 is when we usually expect to see a lot of what the drug is going to do. And that's where the benchmark has typically been between around week 12 and week 16 for a primary endpoint. And by that point, it's close to a 60% response in these patients here with observed case data, which it rivals or is better than a lot of what's been out there before. Week 16 is difficult because, again, there is, I think, a limit to how much change can happen with 16 weeks. And why I'm most impressed with this drug is, honestly, once you get to week 48, which we'll see that data in a moment here, and even when you see the year 2 and year 3 data that's been presented at conferences lately, it just feels like that upswing continues for a lot of patients. Like, they hit high score 50 at this point, but that's because they're on their way to 75 or on their way to 90, as opposed to other drugs where I feel like they plateau earlier. And so seeing that nice tail where there's continued improvement, more healing as more time passes, has been what's impressed me the most.
And what we found with patients that are on it more long term, they absolutely do not want to stop the treatment.
Yeah.
They are so much better. And
Mm-hmm.
you want to make sure they tell you if they're having any kind of problem, because you don't want them to hold it back because they're afraid you're going to stop the drug, which they don't. You have an open discussion with them, but they definitely don't. What we're seeing is people are so much better. They don't want to stop, and the lesions they're getting are so much smaller and so much less painful. I've seen that pretty consistently, I have to say.
Absolutely. And I mean, being part of the clinical trials, it's had, I think, 4 years altogether, a little over 3 years altogether in the extension phase. And so we have patients who are just getting to the end of that. And it's like always a little sad because I know those patients so well by the end of it. I've seen them every 2 weeks for a long time, every 4 weeks for a long time. But they are like so much better and have been, so grateful and excited to like talk about it with other patients and stuff like that. I mean, it's been very impressive for those patients that have, been willing to hang in there for 3 years, driving hours sometimes to our clinical trial site. because it's like it just made such a big difference for that. And so it just something that holds up that long, has been so steady, is such it is so reassuring to not feel like I'm just gonna have to pass it off to the next thing for so many of these patients after a couple of years.
I'm not much of a buzz phrases, but it truly is life changing. It does fit in that situation. It makes such a big difference.
Yeah, no, patients that were having trouble working, and it is really life altering, and you see them start relationships, and then sort of it can be a huge difference for a lot of them.
People avoiding intimacy for months, and then coming in and saying, "Hey, I don't have to deal with that anymore." It's far reaching. It
is, absolutely. And so again, this is just an example here of a response you would potentially see for a patient. This is a patient that has 3 draining tunnels, not all pictured here. If this was maybe a chronic lesion where you palpate out and feel a ridge around this, there might be a draining tunnel here, but it has at least one inflammatory nodule here. And classic story of black clothing all the time, sleeveless shirts at the beginning of the trial are probably going to be something they're going to avoid for the most part if they've got active disease. But the idea that you can make this redness go away, let there be subtle scars by the end, makes a huge difference. And so for a patient like this, again, some of the damage has been done, like this little ridge scar is going to always be present in that sort of upper part of the week 16 pictures. But even in 16 weeks, much less redness, no more bleeding, can probably sort of have more like a freer choice of clothing because they're not constantly having that little bit of drainage that's going to show up on their clothing. And then again, for me, the 1-year data is one of the most impressive parts, right? You see very quickly here that there's improvement in this high score 50 by week 16 that clearly sets itself apart for placebo. Placebo quickly catches up to that. And then you see, again, this slow upswing that happens, right? It's not just that you see a plateau or a very slight decline of, oh, look, just a few patients fall off therapy as time goes on. There is, again, this steady improvement. And I want to make sure to get to this next one here. Again, this is week 40. Like if you have a high score 50, will you sustain that over time? Most patients, yes, are going to have very good stability as time goes on. And this is a modified. This is like kind of the numbers here are slightly lower because it's excluding certain patients who had things like antibiotics or other things that excluded them from the analysis down the road. But even with it being more stringent, again, you don't see it fall, right? You don't see attrition that's happening over time. This is really, patients, holding in there very well. And then when we look at higher response rates, again, this is, to me, some of the most important data. Like high score 50 is nice, and to say 60% high score 50 just about by week 16 that grows up to 80% over time, that's the large majority of patients seeing a respectable amount of improvement. That's great. But I know some of those patients are not going to be as good as they want to be, right? Once you get to high score 75, again, 40% here by 16 weeks. And that grows to 60%, a majority of patients with 75% improvement, right? So that's somebody who had 8 or 9 lesions to start with, getting down to just 1 or 2, right? A very sort of strong response as opposed to 8 going down to 4. And then for high score 90, 23% up to 42%. So that is close to a majority who are 90% better. Very difficult bar to hit. And then you have 30% who are have no inflammatory lesions, right? The idea that again, 29% may feel like a minority, and okay, it's just 29%, but I think we've seen enough, you've probably all seen enough HS patients to know that this is really difficult to do, right? The idea that you're going to have a patient, 1 out of every 3 times just about come in after a year and say, I have no activity of my HS at all, like I am quiescing, and these are moderate to severe patients. These are not the mild patients that have 1 or 2 lesions. They have early 2 or 3 disease with scarring. Most of them have tunneling, a lot of tunneling, and many lesions. So for 30% of them to come and be like, Doc, I'm not hurting, I have nothing that's painful right now, no nodules or abscesses, that is an impressive feat. And with the year 2 and 3 data, there's a continued improvement as it goes on that I'm sure that will be in later decks.
But if all those lesions went away and they did have an increase in the draining tunnels, or they had an increase in the abscesses over what the baseline was, even with all the reduction in lesions, they would have not been counted as a success. So what's happening underneath is also being suppressed. That's how I interpret that, right?
Absolutely. Yeah, that means that, they didn't have, things like, more draining tunnels showing any sort of advancement of disease either.
Right.
And that segues into one of these next ones here that kind of talks about, again, not just reduction of abscesses and nodules. You see this very, impressive reduction in average lesion count for abscess and nodules, but the idea that no new draining tunnels had happened, or there at least wasn't an increase in draining tunnels over the course of a year, that means you have kind of stop the disease from getting worse and spreading with that type of long-lasting damage from being done. So I tell patients, number one thing we have to achieve is that you're not going to be worse as time goes on. You're not building more surgical burden. You are not seeing it spread to new locations, hopefully. And again, this doesn't capture all of those things in the single statistic here, but it means that those types of lesions have been sort of hopefully stopped in their tracks. And you have, gone further than that, probably by reducing what's around that's inflamed, and you can make sure that you sustain them, right? The hardest part, the patients who, get the high score 50 and 75, again, often you stop new lesions from coming. The sort of standalone abscesses and nodules are probably not coming nearly as often, but they just have those chronic tunnels where it is just within that tunnel, an abscess may try to form. It's typically those old stubborn areas that just haven't quite resolved all the way, that they're still having some ups and downs. And in real life, I would be using this medication, 6 months to 9 months in, we'd probably be, or even a few months in, we'd be thinking about surgically attacking some of those areas that are most stubborn. So in real life, I feel like success is even higher because I get more patients clear with that combination approach of medication plus surgery to fix those most recalcitrant areas. And that's where, again, I think the reality is going to be that we do even better. And so what does that look like for a patient like this who has, tunneling and scarring that's relatively extensive here in the groin area? Somebody who's going to be, again, from an isolation standpoint, potentially, very hesitant to sort of, think about relationships and how am I going to explain this to other people? There are many patients, who have very healthy relationships, great communication with partners. It does not hold them back, 100% of the time, but it is often a burden. And so the idea that you can get somebody to where it is something that is not going to be kind of having as much drainage or odor, things that they feel much more confident about, is a huge shift for them, right? And this is the type of patient that in 48 weeks, in 16 weeks, there'd still be quite a bit of redness, that purplish color that's around here, a lot of that post-inflammatory erythema, probably like a little bit of drainage and maybe a tiny bit of open skin. But by a year, you have a chance for those patients who are really great responders to heal to a really great extent, right? Like there is still subtle marks left behind here, but this is a really impressive response, where this person can feel like I look down, I know that I had HS in the past, but I'm not hurting, and can probably feel much more confident about, explaining what's happened, that they have these old scars rather than areas that are actively draining.
So if you're, intervening with some type of surgical procedure, de-roofing, which sometimes can be more extensive, obviously, you keep the biologic therapy going, correct? Right?
Absolutely.
So you don't have to stop and give them a break, or I get that question a lot. You just keep going with the therapy, correct?
Yeah, I absolutely do. Even in the trial during the extension periods, we could offer surgery to some of the patients where it felt like they really needed it because they're just 1 or 2 holdout areas, and I didn't want them to be stuck for 2 years not being able to intervene. And in real life, regardless whether it's TNF inhibitors, IL-17 inhibitors, I have a very low threshold just to keep them going, because the counter argument to that is, HS, when it's highly inflamed and that affects wound healing much more than the biologic does most of the time.
Exactly.
To sort of operate in an area that's highly inflamed, it often stalls out and gets hypergranulation. The better control the disease is, the more likely you are to have good healing. And I've sort of had it out with a few surgeons over time about not stopping these medications ahead of time if they're doing the surgery instead of me. And saying, over time they've been much more flexible. Like there's pretty good data for TNF inhibitors, at least for inflammatory bowel disease surgery, for joint surgeries, things like that is perfectly fine, doesn't increase infection rates or healing complications. And in HS, what's mostly out there is pointed to similar things. There have been a little bit of RCT data for TNF inhibitors that's been very reassuring. Looking back at sort of cohorts of patients who are treated, it's gone a little bit back and forth with whether or not TNF exposure was related to higher rates of recurrences, but that's how you have to keep in mind that patients with worse disease are more likely to be on TNF inhibitors. So there's a lot of bias that gets introduced in observational studies. Things that have been well corrected for across disease states have mostly argued that the impact is probably very negligible from being on a biologic. And I argue that disease control is much more important. Like even if there was a 5% increased chance of wound infection, like I can treat that relatively easily, right? But if they have a much higher chance of developing HS somewhere else, like you're gonna have to do surgery for that potentially, right? That's a much worse outcome than a wound infection in a small percent of patients. And I don't even think it's not even anywhere near that high, probably.
Yeah, you give them time, they'll find out the dermatologist is right. Just give them time.
That's right. That's exactly right. And most of them are pretty good. I've got a good cohort of surgeons that I communicate with, and they're all pretty on board with it at this point. All right, so let's look more specifically at those patient-reported outcomes. Like Dr. Del Rosso mentioned earlier, pain is that thing that they care a lot about, and we should be focusing on it. And luckily in these trials, there was a lot of really nice data collected on things like pain, itch, odor, and drainage. We're going to focus mostly on pain here, just remembering, of course, that with your pain scale scores, no pain is going to be down here at 0, or 0 to 1 is considered is going to be your no pain. Mild is 1 to 4, 4 to 8 is your moderate range, and 8 to 10 is severe. And sadly, a lot of these patients deal with severe pain on a daily basis. And so we got a couple of inverse scales here. So these are patients who reported having 0 to 3 pain, so no or mild pain to start with. And that was a relatively rare thing in this population to start with, right? Most of these patients, are going to tell you they have pain beyond 0 to 3. And as time goes on, by week 16, again, pain is often like the first sign of things improving, right? The inflammation dies down, pain starts to improve within a few weeks even, the drainage starts to slow down, it kind of often very well within those first 4 to 8 weeks, and then that healing happens. So the disease response, the way we measure it, lags behind. But by 16 weeks, half of patients here feel like they're in that mild to no pain area, and then by a year, 65%, right? So a big shift in these patients. 2/3 of patients with mild or no pain is an impressive number. If we look at that in the inverse, we see that 81% of patients, start off with a moderate to severe pain score of 4 to 10, and we get that down to less than, almost 1/3 of patients by the end, right? So that's the majority of patients doing better, and most of these patients in this 36%, right? Those are your people who aren't quite hitting high score 50 probably, or maybe you're at high score 50 and they still have, a couple lesions around that stay painful all the time. I would guess like their overall burden in terms of like how widespread and how affected they are is better, but it's just, one abscess is enough to be miserable.
Right.
And so they can sort of be rating their pain because it's just, that day they happen to have a very bad lesion.
It's not really quantitative to how many painful lesions they have, just the overall severity of the pain. Yeah.
That's absolutely right. So again, you sort of flip this scale here, where all of a sudden you have a very large percent of patients, a majority who have minimal to no pain, where they started off with very severe pain.
Right. It's good.
And then there is a newer tool that's been used called the HiSQAL. So this is a little bit of a spin on the DLQI. Right? DLQI doesn't measure things like drainage and odor that are very important in HS. HiSQAL also measures things like depression and anxiety, embarrassment around disease, things that are in the DLQI, and then goes in a little bit more detail about physical activities that are impacted by HS, more so than DLQI does. So this was developed specifically with HS in mind as a way to measure quality of life impact. There's these three subscales here: symptoms, psychosocial impact, and then how much it affects daily living activities. So sort of physical abilities, symptoms, and psychosocial impact are those three groups. And then the total score you can get up to is 68. And most patients end up in a severe to sort of very severe range to start with in studies. And if you look at, the baseline score was a 24. I'm going to go back at that, which put us into a severe to very severe range. And on average, those scores drop down to the mild range by week 48. And by week 4, again, just I think less pain can automatically kind of affect a lot of these scales, because not only are they going to report less pain as one item, but they're going to say I'm also more physically able to do things relatively quickly. And I think a lot of this further improvement that happens over time as they get sort of used to hurting less, and they are more willing to get out there, and they have less psychosocial embarrassment or less issues in those regards. So I think probably the functional parts improve a little bit more quickly, and then over time, some of the psychosocial burden improves as well. Safety, of course, is the other side of the coin anytime we talk about medications. And fortunately, there is plenty of historical data out there about IL-17 inhibitors in general. And for the most part, it's very consistent with what we're familiar with from those other drugs. There are a couple things that I'll kind of point out that are slight differences. For the most part, what you can see here is that things like serious infections are pretty much numerically slightly 1 versus 0, but almost identical across the two groups. So no major signs for serious infections, but anytime we use something that affects the immune system, we're going to mention a very small possible risk of that. The one thing that I always mention to patients, because it does come up in about somewhere from 1 out of every 8 to 10 patients or so, are the oral candidiasis, right? So in this study, there were about 7% that you can see in this group. Longer term, closer to 15%. And so I mentioned to patients, there's a small chance that because of how this medicine maybe affects, how yeast can grow in the mouth, is that you could develop what's called thrush, where you might see some whitish stuff on your tongue. It may feel a little bit sensitive. If that happens, I'm happy to give you like a swish or some antifungal pills that will quickly fix that. The vast majority of patients in the trials or that I've treated in real life, if they've developed thrush, they say, I don't care, give me that antifungal pill, I am better and I am not stopping this drug, right? So it is a bit of a nuisance more than it is something that's typically dangerous or that kind of interferes with treatment over time. Yeah, I think, with lots of drugs we treat, whether it's, dupilumab that causes ocular manifestations or a JAK inhibitor that causes acne, it's one of those things that some patients are going to be sensitive to it. Luckily, we can manage this relatively easily, actually, though. So it's unusual for patients to be so bothered that they'd say, I'd rather my HS be worse than not deal with this, right? To them, the trade-off is very clear in this regard.
Yep.
Otherwise, things like hypersensitivity reactions, eczematous reactions can sometimes happen. When I've seen those, they've typically been in places like the skin fold. So kind of an inverse pattern is probably the most common. For a lot of the patients, their HS is doing great. They want to push through it, using some topical steroids temporarily or other things to kind of manage it. Usually works out just fine. Occasionally it's enough of a burden you have to think about something else, but for most patients, we can get them through it. And in the long run, I think it often does much better over time. So it's, a relatively infrequent problem and usually something you can manage through okay. There are, warnings on the label about suicidal ideation behavior. You can see here there was one case reported in this placebo group, and I think a total of two or three, there were a handful kind of over the longer treatment period. It was numerically slightly different than the placebo group, but it was not a statistically significant difference. And if you compare it across, other IL-17 inhibitors, IL-23 inhibitors, TNF inhibitors, and you look at rates of suicidal ideation and behavior, it's actually pretty much the exact same as you see across all indications. I think, IL-17 inhibitors, since the days of brodalumab have been under a little bit of a sort of, more highly scrutinized lens in this regard. And so it's watched much more carefully. But I find the data to be overall very reassuring. If you observe enough people, you're going to see things like this happen, just like with things like isotretinoin. And so for the most part, or you can mention it to patients and say, like, if your mood seems different when you're on it, or if they have a history of psychiatric illness and suicidal attempts, things like that, you can, be careful about how you're counseling. But for the most part, those events, I would consider them like quite rare and probably not much different than most of the other things that we treat with.
And it tends to be higher in people that have these diseases, these types of diseases unrelated to the treatment that they're on. If you look at psoriasis, hidradenitis suppurativa, even some of the other disease states like alopecia areata. I mean, these are tough things to deal with every day of their life, right?
Yeah, the rates of suicide attempts and completed suicide, there's a significantly higher risk in general in the HS population, and it's often related to the burden of the disease over time. Improving their disease, is much more likely to improve their mood over time than it is to negatively impact it. So, most patients will tell you, like, I don't want to see a psychologist or psychiatrist to make my disease better. I will be happier, right? So the trade-off is clearly in the positive direction for the vast majority of patients.
Just the same story we have with oral isotretinoin,
Exactly.
Absolutely.
Yeah, most patients, with IL-17s, we think about inflammatory bowel disease. There was actually not an exclusion around inflammatory bowel disease in the study, which was pretty interesting. So there were a handful of patients with known IBD in the study. And so I think there were a couple of flares that happened, but it was not necessarily considered, out of the normal range of what you would expect in a population, especially with HS that's got a known high risk of inflammatory bowel disease.
I think the label in the case of Bimzelx says if they have active inflammatory bowel disease, don't do it. Doesn't even mention if they have a prior history, though.
Exactly.
So you would address it, right? You'd obviously address it.
That's absolutely right. Yeah. So of course it's off label with biologic combinations and things like that, but I will tell you, we have, I absolutely have patients where, their IBD is well controlled with another therapy, their HS is raging out of control. And so we add, bimekizumab to it. I always talk with the GI docs and we're very careful about that, but a lot of them say, yeah, if I've got good control and I can monitor them carefully, we'll give it a go because of how bad their HS is. So be very careful, talk with the GI docs, make sure you got a team that's dealing with those things. But just ask the right questions, or if patients start to experience symptoms, you're going to ask them about it.
Right.
I wouldn't typically say, like, if they've got a family history of IBD, they have to be excluded. There's, different thresholds people use, but, generally, a remote chance of IBD developing is not a reason not to treat somebody's HS.
It's a case-by-case basis. Case-by-case
Exactly.
basis, yeah.
As we look again further out here over 2 years, in general, rates of these things happening, tend to get lower as time goes on. The drug is well tolerated, so things like serious adverse events overall, kind of were less in the second year than in the first year, which is always reassuring that we don't see anything building up. Death was, I think there was one death. There was, very infrequent, what was expected in line with this population. And then otherwise, oral candidiasis was the main symptom to come out, which is a bit better after the first year. Strangely, vaginal yeast infections, if they are higher, it is like very minimal, if at all. And maybe it's just some difference about the role of IL-17F and the oral mucosa versus the vaginal mucosa, but some patients worry about that. I think the risk of us giving them antibiotics all the time is probably a higher risk of vulvovaginal candidiasis than it is of being on a medication like this.
Yeah.
So I kind of remind them of those trade-offs of, antibiotics aren't, the most perfect drugs in the world either. And if I can give you less antibiotic over time, potentially, that's a good trade too. And then hepatic events were also very, very unusual over the course of time. There were a few instances of elevated LFTs. In general, I don't always check them and monitor them unless I have some reason to, like I think that there's something that's changed for a patient. But again, it's one of those things that if a patient develops liver disease and you're thinking about different causes, having in the back of your mind that maybe it's a very rare association. And we talked about IBD a bit already. And I've kind of been through these things already. I will usually check a TB test before starting, mostly to satisfy insurance, unless because I think there's a terribly high risk with these drugs. But usually you're going to want to check that in the beginning, and for at least anybody with significant risk factors every year at a minimum. And then most of these others we've already touched on, so I won't hit them again. Immunizations are typically fine for non-live vaccines while you're on a medication like this. So I wouldn't tell patients they have to stop it while they're on a drug like an IL-17 inhibitor. And again, I think we kind of talked about the rest of these already, so I'm not going to run back through them again. For dosing, your typical HS dosing is going to be higher and more frequent than what it is for psoriasis. So if you're used to treating psoriasis with this drug already, make sure that you're using the HS dosing. It's going to be 320 milligrams every 2 weeks for the first 16 weeks. That's your loading period, so a 4-month loading period. And then after that, you're going to switch out to every 4 weeks. And in the trials, they had groups that did every 2 weeks versus every 4 weeks in the long run. There wasn't enough of a difference there to say that they needed to continue it every 2 weeks sort of in perpetuity. And so that's why the approved dose is the way that it is. There are pens or preloaded syringes for whatever your patient prefers. The original formulation was just with 160 milligram pen, so patients had to do 2 of those every time. Much more convenient if you let them just do 1 pen each time. So I would try to make sure to select your 320 milligram pens or syringes as opposed to the 160 for HS.
The 160 is for the pure psoriatic arthritis, correct? That's why it's a lower dose. Okay.
Exactly. And so yeah, we wouldn't have much need for it in dermatology anymore. But again, if you, for whatever reason, had a patient that started on 160s and they're still on it, and you just don't want to have to fight the insurance or something, you can continue them on that. I have some patients who prefer the syringe. They just like the control of how fast they can inject, things like that. There's all the usual tricks for if they have pain with injection, although it doesn't tend to be all that severe with, put it against your skin for 15 minutes and let it get up to body temperature as opposed to just room temperature, or, ice pack beforehand, numbing ointments if they need help with it, but most can tolerate it just fine. And again, we work through that here. Again, for psoriasis, again, it's just less frequent dosing, every 4 weeks for loading for 16 weeks, and then every 8 weeks. So it's half as often in psoriasis as compared to HS. There are plenty of good patient support programs like with a lot of the other drugs that we use. So I think it will be better and better when it comes to access. The first year is always the trickiest when it comes to step therapies and working through other things, but as time goes on, it's going to get better and better. Already for many patients, it can be first or second line. And then for those that can't get access, there's a bridge program that goes for up to 2 years. You do have to resubmit to insurance every 6 months and have denials, but that allows patients to get started with it and then hopefully continue it over time if they have a great response. And so just, summarizing things here, again, things like pain and even sort of those early responses can happen as soon as 2 weeks. Shooting beyond high score 50, highly respectable rates, high score 75, 90, and 100. So again, 30% of patients over the course of the year who feel like they have 0 inflammatory lesions is a high bar to hit. and it's been done with this medication. And then I think what, again, is probably one of the most important things, nice sustained control where it doesn't feel like they plateau after 3 or 4 months and then you kind of just wait for them to fall off the edge of the cliff. So for this, you get that really long lasting response. And you know, PROs like pain, high squall, how they function, how they feel about life in general, you know, tend to typically improve quite well on those that respond.
And documenting all of that's important when it gets to the point of trying to get coverage, because I'm looking at, we have a few minutes left and a couple of the questions that came in, Chris. I really
Sure.
appreciate your insights. It really shows how often you see these patients and how much you deal with. But the whole idea of getting it introduced sooner, and you know, the people that are pushing back against us doing that we have to deal with, are looking at what's in the label and using those criteria to sometimes say, well, I'm sorry, we can't approve it yet, the patient's not severe enough. How do you work with, when you really want to get a patient on earlier for all the reasons you mentioned, how are you actually able to be successful in doing that?
Sure. So, you know, usually the indication is moderate to severe HS, right? You know, if they throw clinical trial criteria in there, they could say at least 5 lesions, something like that. And so the biggest thing for step therapy and getting around the insurance usually is they want 3 months of or intolerance to antibiotics, right? That's almost always has to be a box you have to check. And almost every patient we see has been on antibiotics at some point, often for at least 3 months, or they've been on it for a short time and they've had stomach upset, or they've had, you know, vaginal yeast infection or something that has been a reason it's been difficult for them to tolerate it. So usually you can check that box pretty easy. Or, you know, you give them doxycycline, you tell them not to eat any food with it for that first day, and they'll tell you my stomach hurts, and you've got to check that box for them.
They're going to do that
so
anyway because they don't listen.
Exactly, that's right. And then, you know, after that, you know, and if they have had relatively frequent lesions, you know, a lot of patients have, you know, at least a little bit of scarring or something that would help them qualify as Hurley 2 even. So you can often document pretty easily that they've got Hurley stage 2 disease, or just recalcitrance to other therapy with frequent lesions, you know, that, you know, even if it's not the day they see you, they're like, look, you got me on a good day. I've only got a couple spots that are active, but there are days that I've got, you know, 5 or 10 lesions, right? Like documenting that they have disease activity that's in a moderate to severe range, you know, usually is what you have to be able to put in your notes and be able to check the box for.
And palpating, you'll find more lesions. Don't forget about the palpation part of it. I thought that was really important, you mentioning that.
Yeah, very often, and asking them to show you, you know, you know, are there spots that are tender right now? They can often point it out. So, you know, usually it's not so stringent. They want you to say exactly, you know, that they're going to be expecting lesion counts and things like that. But again, if you think they're in that moderate to severe category, you know, that usually qualifies. The biggest challenge is that with biosimilars out there for adalimumab, you often have to step through that first. It's not 100% of the time, but it's relatively frequent now. You know, so again, it's somewhat at the mercy of insurance companies. If you think this is absolutely the best thing for the patient, again, bridges to get them started and then continuing them on it over time is very reasonable to do also. But yeah, usually those are the big things to be able to document.
So just to sum it all up, because we're pretty much at the end, and once again, I really appreciate your insights. I do a lot of this, and I still get a lot out of hearing other people, their experiences. It's been tremendous. But what about patient expectations? You're talking with them the first time. They've had a frustrating time, as we explained. How do you deal with explaining to them what they realistically should expect in the time frame that they have to allow before they pull the plug too soon?
Absolutely. So, you know, I always tell them, you know, my patient starts to run out, you know, if a few months goes by and you're not seeing anything at all, right? Like, you may not be the best you're going to be by then, you know, but these curves, you know, it's not that you see, you know, no activity for 3 months and then a straight vertical bar of improvement, right? It is steady improvement that happens over those first few months. So I say, at minimum, I want to see momentum over a few months, and that's going to be, again, less pain, less drainage. There's still going to be areas that need to take more time to heal. Or again, there's some of that tunneling and scarring, the way that skin is remodeled, like it might take surgery to really sort of get that to be just flat scar in the long run that's not symptomatic anymore. And so, you know, let's get you back in 3-4 months, you know, make sure that you're moving in the right direction at a minimum. You know, if you are by that point, that might mean with at least a drug like this, that you're going to see continued improvement as more time passes. And we're going to start thinking about, if you're stable, are there areas where you'd want to pursue surgery, or just, you know, give it some more time and kind of see where it goes. Or if it's not better, we're going to change it, right? We have a few options at this point. We have things where I can switch you out and do other things, whether it's, you know, other on-label medications you haven't tried yet, you know, off-label things, because we live in that world a lot of times when it comes to HS. So I let them know, look, if it doesn't work out with this first one, other options are out there.
We have other options. Chris, I want to thank you so much. Like you said, we can talk about this forever, but we're not able to do that tonight. I want to really thank you for your time, and I'm sure everybody listening got a lot out of it. We want to thank UCB for making this all possible. Yes, we talked about the drug, but we talked a lot about the disease. So thank you. I'm looking forward to meeting you in person.
Absolutely. Yeah, I look forward to it too.
Okay. So we'll turn it back to Ashley, right? Is Ashley there?
Thank you. Thank you, Dr. Del Rosso. And thank you, Dr. Syed, for a great program. Now that we are finished with that program, we would like to invite everyone to join us for a program, another one this week that we have coming up on October 16th on Thursday, vitiligo real world case studies. So please register at idefeducationalseries.com for that upcoming webinar. And thank you again for joining us this evening.
So one chronic difficult disease to another. So
That's right.
in 2 days. Yep. Thank you. Thanks, everyone. Thanks, Chris.
Yep. Thanks for having me.